Thompson. And I want to ask each and every one of you a question out there watching our show today. We have Dr. Marshall Silverman here with us, and he's going to answer all of those questions.
I'll do my best.
Thank you for joining me today.
You're
well,
welcome.
before we even get started, let's talk a little bit about you. Can you tell us a little bit about your background?
Well, I'm an internist, a board-certified internist. And I moved with my family here to Charlotte in '98 and joined a small practice and had a busy practice until about middle of 2011. And I was approached by a group here in town called Signature Healthcare. They are a concierge medical practice. And they asked me if I wanted to come work with them. And the job was closer to home, and it was medicine at a slower pace with a depth of relationship with your patient that is very difficult to achieve in what is now considered a traditional practice. We have 300 patients per physician, as opposed to the 3,000 or 4,000 patients per physician that the average physician has in the community. So that allows us to be more available for our patients, spend more time with our patients, and develop deeper relationships, get to know them better, be available more readily for them when they need us. And it really is a throwback to the Marcus Welby MD days, where the doctor was there and a part of your inner circle of friends that you trusted, and vice versa. So that's where I am now. I've been there since July of 2011, and my practice is just about filled up, not quite there, and I love it.
So our show today is going to talk about diabetes. We're going to focus on that. What exactly is it?
Diabetes, in the shortest answer, is a disorder of glucose metabolism. In English, your body can't get the sugar out of the bloodstream and into the cells where it belongs. Okay. So just about every tissue in your body uses sugar, glucose, for fuel. You eat, whether you eat a donut or whether you eat brown rice or whether you eat an apple, that nutrient makes its way into your body. Eventually it gets converted by one way or another into glucose. The glucose gets into your bloodstream, circulates throughout your bloodstream, and gets deposited, gets escorted, really, and we'll talk about that later, into your cells, where the glucose is used for the fuel to drive everything you do, to power the cells so that you can survive. Diabetes is a problem where the blood sugar doesn't get out of the bloodstream. And it never makes its way into the cells, or it does, but not in an efficient way. So what ends up happening is the blood sugar, the glucose, is circulating throughout the bloodstream, and eventually it just gets peed out in your urine.
So that's why we have to take a urine test.
That's why a urine test. If you're pregnant, you take that's one of the tests you do. You take a urine test to see if you have diabetes. As a matter of fact, that's where it got its name. Diabetes mellitus actually comes from a word that means sweet urine. Because that was, in the olden days, that's one of the hallmarks of the diagnosis. That's how they could tell us what it was. The problem is that amount of glucose circulating throughout the bloodstream is toxic. It's toxic to your kidneys, it's toxic to your eyes, it's toxic to your small blood vessels, it's toxic to your nerves, and it ends up causing damage to all of those organs over time. The reason the blood sugar isn't getting out of the blood vessels and into the cells has to do with insulin. All right, we've all heard of insulin.
Yes, I've heard of it.
Right, insulin is this hormone. It's manufactured by your pancreas, which is one of your digestive organs. And the insulin is secreted by the pancreas into the bloodstream in a way that matches the amount of blood sugar that's in there. Okay? So if you eat a big meal with a lot of carbohydrates in it, a lot of sugar in it, then your body secretes a lot of insulin in order to grab the glucose and escort it into the cells. Okay? So imagine your cells have a door to get in, and the glucose is banging on the door, it's not going to get in. But insulin is the key to the lock on that door. All right? So the insulin is what allows the glucose to get into the cell. It is the key to getting into the cell. What if you don't make any insulin? Don't make any insulin, then the glucose is circulating forever in the bloodstream and out in your urine, and it's never getting into the cells, and you lose weight because you're starving yourself. The glucose isn't being taken up by the body. That's type 1 diabetes.
You know, that was my next question for you. What are some of the signs or symptoms of diabetes besides the urine?
All right.
What are some other things you look for
Great
as a doctor?
question. I want to answer that, but I want to go back to the more important, not the more important, the more prevalent form of diabetes, which is type 2 diabetes. In type 2 diabetes, your cells become resistant to insulin. So the insulin, it's like somebody broke the key off in the lock, and the insulin tries to open up the door to get the glucose out of the bloodstream and into the cell, and the door's not opening. So the pancreas makes more and more and more and more insulin in order to overcome this problem. Eventually, enough insulin builds up that it actually just knocks the door down and it lets the glucose get in. But that's actually a problem. It's actually not good for your body to have to make that much insulin, and it's certainly not good for your body to be resistant to the actions of insulin. That's type 2 diabetes, and that's the more common type. That's the adult onset type of diabetes. That's the one that is linked with obesity, linked with certain at-risk populations, certain lifestyles. So let's say that you are somebody who is at risk for diabetes, for type 2 diabetes. How do you know if the symptoms that you're having are those symptoms of diabetes?
Right.
Well, as I said before, the glucose gets spilled out in your urine, right?
Right.
But not only is it sweet urine, which, you know, you kind of think about who's the first person to discover that? I don't want to go there. But, yeah.
Did they taste
Yeah,
it?
who knows? It's kind of like the first person that says, I'm going to eat the next thing that comes out of that chicken's backside, right? But still, the glucose is what's called a diuretic. You know what a diuretic is? Something that, like a water pill, it makes you pee. Well, glucose is a diuretic. So people who are spilling glucose into their urine, they're peeing all the time. And what happens when they pee all the time? They get dehydrated. So what do? They're drinking all the time.
And so they're still
So they're thirsty all the time, and then they're peeing it all out. They're drinking, they're peeing. And then not only that, but in the more severe advanced cases where the blood sugar is really high for a long period of time, they'll start dropping weight. Because again, their energy, the glucose, isn't getting absorbed into their body. Okay?
But I'm confused. You said that most people that are diabetic, they tend to be overweight.
Yes.
But they're losing weight?
Right. So here's a typical picture. You'll find an overweight person who comes into the office and says, Doc, I feel I'm doing great. He said, yeah, I'm peeing a lot and I'm drinking a lot, but man, I've lost 50 pounds in the last 3 months. And I said, well, did you change your diet any? He said, no. I said, are you exercising more? I'm just doing something right. No, you're not doing something right. Your body's doing something really, really wrong. Now, with a type 2 diabetic, the typical type 2 diabetic is unlikely to lose so much weight that they go below a normal weight. They normally start off at an obese weight, and then they'll start losing weight. And usually by the time they've lost, 20, 30, 50 pounds, first of all, unfortunately, most of these people still aren't at their ideal body weight after losing that much weight. And second of all, they're having so many other symptoms, whether it's fatigue or whether it is peeing or drinking, waking up 4 times at night to go to the bathroom.
Oh, that's not good.
Right. So any of those things are going to bring them into the office to get attention, usually before they lose so much weight that they're actually underweight.
Now, you mentioned a type 1 diabetes, a type 2. Are there any others?
That's a great question. For the purposes of education, really type 1 and type 2 are the best ways to break it down. And they account for the vast majority of diabetics. There are patients who are, for instance, gestational diabetics. These are the women, any woman out there who's ever had to go and drink that nasty glucola and then have to go pee, take their blood drawn or pee in a cup afterwards when they're pregnant. That is a screening test for gestational diabetes. And the reason you really shake the tree hard to see what you can shake out in terms of a diabetic, you really test them aggressively, because diabetes in a pregnant woman is associated with childbirth issues.
Ah.
And so it can really do have some problems with childbirth if you allow a woman who is diabetic to have her sugars uncontrolled during her pregnancy. So there's gestational diabetes. Interestingly, Cynthia, that goes away after pregnancy in 2/3 of the women who have gestational diabetes. 1/3 of the women will continue to be diabetic after pregnancy, and that was their defining, triggering moment of becoming a diabetic. Another 1/3 will develop diabetes at some point later in their life. And then 1/3 will have gestational diabetes and never see diabetes again throughout the rest of their life. So it's 1/3, 1/3, and 1/3. 1/3 stay diabetic, 1/3 never become diabetic again, and 1/3 develop diabetes later on in their life.
If by chance you don't go to the doctor and he diagnosed you as being a diabetic, what will happen to you eventually?
If you don't go to the doctor?
Besides death.
Yeah.
Like, what are some things that if you don't treat diabetes will happen to you?
And the funny thing is, Cynthia, you say besides death as if that's the worst possible thing that can happen. It's not.
Oh, it's not?
No. Dialysis. Losing your legs. From the circulation and from the nerves, going bad and from infections, blindness, heart disease, stroke. I mean, it's a pretty sad reading list. And you ask anybody, which do you fear more, a stroke or a heart attack that kills you, or a stroke that leaves you paralyzed on one side of your body, or a heart attack that kills you? They're going to say, I'm more scared of the stroke than the heart attack. And so, yeah, death is one possible outcome, but there's things that are worse than that. And those are the things that I mentioned: blindness, amputations, kidney failure, and dialysis. Now, don't get me wrong, these are not the acute complications of undiagnosed diabetes. These are complications that really take years.
Oh, really?
Years to develop, absolutely. Years of untreated or years of poorly treated diabetes will end up in those categories of all the different, we call that end organ failure, where the end organs, the nerves, the blood vessels, the kidneys, the eyes, those are the ones that become damaged. In some people it can take 20, 30 years, in other people it might take 10 or 15 years.
Really?
But we're talking years of poorly controlled diabetes. In the acute setting, death is a more likely outcome, because what happens is, and I've seen this before, patients diabetic, they don't know, they live alone, they don't know they're diabetic, and they end up just one day they go into what's called a ketotic coma. They basically fall on the floor, they're in a coma, nobody finds them for 2 or 3 days, they die of dehydration. I mean, it is sad, but it is a story that I've seen played out multiple times.
Really? I know science has come a long way. How do we treat diabetes now? I know there's several different ways to treat it.
Yeah, well, the best way, and I'm sure we'll get to this in a minute, is prevention, making sure you don't develop diabetes. If I have a type 1 diabetic, the treatment is insulin, period, end of sentence. Okay? Remember, type 1 diabetics don't make insulin.
Right.
And without insulin, you die. So that's the treatment for type 1 diabetics. There are a few type 1 diabetics who miraculously will have what's called a honeymoon period, where a year or maybe even 2 after they're put on insulin and originally diagnosed, their body starts making insulin again, but it's like the last hurrah before it finally stops and gives out completely. They always end up back on insulin again. Most type 2 diabetics who come to you, especially in this day and age where access to care is a little bit better, and people come to the doctors typically before things have gotten too far out of hand, their diabetes is maybe manageable in the initial settings with lifestyle modifications. And I always push that with my patients. Lifestyle, lifestyle, lifestyle. You eat healthy, which means foods that are not rich in the processed carbohydrates that are so bad for you. I once heard I was listening on the radio just yesterday, the day before, and it was some lady talking about how it was so difficult to prepare healthy meals for her family because a box of mac and cheese was 30 cents and a hand of bananas and fresh fruit or protein or something else that took some time to prepare and was healthier was $2 or $3. And on a budget, which was she going to afford? And you go for the mac and cheese. So that's one of the problems that we're facing on an epidemic scale here in this country is the processed foods that are thrown at you, and it's so carbohydrate rich. So minimizing those carbohydrates really, really helps to promote what's called insulin sensitivity, the opposite of insulin resistance. You want your cells to become sensitive to the action of insulin. Well, one of the ways you can do that is by changing your diet and eating fewer carbohydrates and fewer processed carbohydrates. When I say processed carbohydrates, what do I mean? Well, sure, sugar.
Sugar, yes.
Sweets. Everybody knows that that's bad.
But they're so good.
What everybody doesn't know, the white rice, the white bread, the white potatoes, the white starches tend to be the foods that are they're high glycemic. It just means they're bad for you if you're diabetic or you have that tendency. And actually, for most people, they're just not good. They cause your body to make more insulin, and that's just not necessarily a good thing for you. So we emphasize low glycemic foods, and there's certain carbohydrates out there that have a more favorable impact on how you're on the carbohydrate metabolism of your body, promotes insulin sensitivity, and then exercise is the other aspect of that. You can take somebody who is severely insulin resistant and who's a couch potato, literally. Get them exercising, a brisk walk for 30 or 40 minutes every day. And after 2 weeks, you can measure improvement in their insulin sensitivity. Their body starts handling the carbohydrates and the insulin more efficiently. Your body is so forgiving. You can take a 20-year couch potato who's become insulin resistant over that time and have them just get up and start an exercise program, and within 2 weeks, your body starts forgiving you and start to improve how you metabolize that sugar and reducing your risk of becoming diabetic. If lifestyle modifications don't help and don't reverse the problem for the diabetic, then there's oral medications is another step. And there are all kinds of different medications. If you remember that the main problem is your body's sensitivity to insulin, then they've developed multiple medications which target that. Try to improve your body's insulin sensitivity, or try to improve how your body secretes insulin and to match it when your body needs it the most. The research is amazing out there. And we're coming up with new diabetic drugs. Every decade is usually a spate of 2 or 3 or 4 new drugs that come out. It's not, a new drug a year, but every year something new and exciting is at least in the pipeline, and then every 2 or 3 years a new drug comes out. So 3 or 4 every 10 years, every decade. Yeah.
We're going to take a short break. When we come back, I want to talk some more about diabetes.
Sure.
Some more things that our viewers may not know about it.
Absolutely.
Okay. Welcome back to Better You. I'm your host, Cynthia Thompson. I'm here with Dr. Silverman, and he is educating me about diabetes. When you hear that people have diabetes, you think that, they have sugar and they have to take a shot. But I've learned that they have a pill form for it now. So it's not always a shot. And there's 2 different types. But I do have a friend that is a diabetic, and she always has to check her blood, prick her finger to check her blood. Why does she have to do that?
People that there is a little bit I'm going to say something that's controversial, and it's going to fly in the face of what makes common sense to a lot of people. But most diabetics don't need to check their blood sugar.
Oh, they don't?
They don't. They don't need to.
But they should?
No. Let me tell you why.
Okay.
The main measuring tool that physicians use to see if your diabetes is adequately controlled is something called a hemoglobin A1C. A lot of gibberish. But what but what it is, Cynthia, it's a way of testing your blood and figuring out a 3-month average of what your blood sugar is. It gives me an average over the last 3 months. So if you had a bad Thanksgiving and really pigged out over Thanksgiving for 3 days straight, your blood sugars are going to be horrible during that time, and maybe for a few days after.
But that would be for a normal person, right?
No, a normal person whose insulin and pancreas and organs are working appropriately, they'll maintain their normal blood sugar during that time.
Okay.
That's normal. Now, there are different levels of abnormal. You don't just go from being a normal person to a diabetic. There's a gray zone in between that we can talk about. It's called prediabetes. And these are people that have elevated blood sugars but don't yet qualify for an official diagnosis of diabetes. Okay? But the 3-month blood sugar average is a way of assessing a patient's not just compliance with their medications, but the response to their medications and risk for developing complications over time. Most of the studies that we have over the past 20 years that look at complications related to diabetes don't relate it to the blood sugar. They're related to the hemoglobin, related to that 3-month average, the A1C. All right? So that's what all the doctors use as their guideposts to decide, is my patient well controlled or not well controlled. They use the A1C. So why check your blood sugar at all? The main reason is if you are given a medication that has the potential to lower your blood sugar to a dangerous level, you need to have a way of assessing that. You need to have a way of testing that. And that's what the blood sugar does. That's what testing your own blood sugar does. That's the main reason. If I have anybody on multiple insulin shots a day, well, even if they're on one insulin shot a day, I'm going to have them check their blood sugar at least once a day because insulin can lower their blood sugar below normal, and that could be dangerous, acutely dangerous. If I have them on multiple shots a day, that means they're a tough to control diabetic. And I'm trying, and I do need to have them check their blood sugars possibly multiple times a day, because I'm adjusting the morning dose of insulin, the afternoon dose of insulin, the evening dose of insulin, all based on this minute data. But if they're just taking a pill a day, let's say 1 pill a day, and that pill has no ability to lower their blood sugar below normal, then checking the blood sugar is not helpful for me. There are some people that say, yeah, but Dr. Silverman, it helps me to know what I can and can't eat. It helps me, I know that when I eat cake and I watch my blood sugar go up to 300, that I shouldn't be eating cake. And when I eat an apple and I eat peanut butter and I see my blood sugar staying nice between 70 and 100, I know that I've just eaten the right thing. And I want to shake him by the lapel and says, I'll tell you it's wrong to eat cake. You don't need to check your blood sugar to know it's wrong to eat cake. But it's a reinforcing tool for a lot of people. If you need that reinforcing, check your blood sugar. If you don't need to.
So if you're diabetic, you can't have any sweets at all?
Oh, wow. Life's too short for that, isn't it?
Yes.
Yeah, so no, that's not true. Most of the people that are coming in diabetic because they ate lots of sweets and they had a genetic predisposition and they weren't exercising enough. They had kind of the whole trifecta going. These are people that aren't just eating cake every once in a while. These are people who's every morning their breakfast, maybe half a dozen donuts. And I don't want to paint the wrong picture because you can be diabetic without doing that too.
Oh, really?
Absolutely. I mean, diabetes is, you're going to get me off subject, but diabetes is develops from really 3 combinations, three things. One is a genetic predisposition, especially with type 2 diabetes. It tends to run in families. Doesn't mean that if you don't have a family history that you can't become diabetic. You still can, absolutely. Because there's 2 other factors that factor into it. In addition to a genetic predisposition to it, there's diet and there's exercise. The diet aspect of it is what we talked about before, the high carbohydrate foods, the foods that are bad for you. And then the exercise, again, if you lead a sedentary life, then you're more likely to become diabetic. And think about it, those 2 things, the diet and the exercise, what else are those things associated with? Obesity, right?
Yes.
So obese people are more prone to develop diabetes, but that's not necessarily because obesity causes diabetes. There is some data out there that says that it might, but it's more because the things that create the obese person, family history, family genes, and lifestyle, also tend to be the things that lead to diabetes.
You know, you've given us a lot of information. I have a list of questions I want to ask you about diabetes because this is new to me. But I want to touch on the American Diabetes Association. What is their role in a person that has diabetes? Can they go to them for assistance?
Again, I appreciate that you brought that up because there is more information that I could give you tonight about diabetes than you would want to hear. And I could keep on going for another 2 hours. And I'm just getting warmed up, right? But the American Diabetic Association, American Diabetes Association, the ADA, is a wealth of information. And I encourage any listener or any viewer who is interested in learning more about this to log on to their website, theada.org. American Diabetics, what is their website? It's the
American Diabetic
Association.org. I should know that. I think, can we provide the phone number for the ADA as well? I think that would be a good thing. What the ADA does is they help to educate people in the prevention, if you're not diabetic but you think you may be at risk, in the diagnosis, if you think you might be having symptoms and want to know, is this something I need to take to the attention of my doctor, the treatment, if you already are diabetic, or the care, if you're a caregiver or a relative of somebody who's diabetic, and you're cooking for your dad and your dad has been diagnosed with diabetes, you got to know what to do in order to help him get a handle on this. Or not to do. Exactly. So the ADA is just a wealth of information. Their website is. They also promote community-based services, just to promote the awareness of diabetes in the community. And there's three I want to hit on. One is the Step Out. It's a diabetes walk that is held every year. Starts in South Park area, and I think it's usually November 2nd, I think, is this year's. And it's just a fundraiser for diabetes to help with the research and with the advocacy for diabetics. The second major event is the Father of the Year Award, which it recognizes a citizen in the Charlotte area that is playing a role in diabetes awareness and also balancing his professional life with his family life. But more importantly, it's a fundraiser for the Diabetic Association. And then the third, I'm probably going to get this wrong, Live Empowered, I think, is the name of the program. They've changed the name a couple of times on me. But it is a program where we target or encourage high-risk groups. And these are mainly African American groups and Hispanic groups through their churches to make the congregations, make the highest risk patients aware of what diabetes is, how to diagnose it, and how to treat it. I mentioned before that there's a genetic component to developing diabetes, and one of the main issues is ethnicity. Hispanics, African Americans, certain Native American Indians are at extremely high risk for developing diabetes.
Do you think it's because of our diet?
No, it goes well beyond your diet. I mean, diet plays a large role in it, but you take an African American or Hispanic and give them the same diet as a Caucasian person, and the risk is still much higher in those other populations.
Dr. Silverman, I have so many more questions for you. Will you come back again?
Absolutely.
I have really enjoyed this, and I have learned so much about diabetes, and I want to thank you again for being on my show.
You're welcome. Thanks for having me.
And I want to thank each and every one of you for watching A Better You every Wednesday night at 6 p.m. here on Public Access 20.